Hi, my name is Siva and I'm here today to talk to you about spinal cord injury or SCI. After introducing the case study, I will talk about the physiological mechanisms responsible for hyperreflexia and an overfull bladder. I will then discuss several cardiorespiratory changes and future complications associated with SCI. Finally, I will outline an exercise intervention program for the case study and describe the signs, symptoms, and management of autonomic dysreflexia. The information discussed in this presentation should direct attention to the complexity of SCI, the importance of exercise in preventing future complications, and in general be of use to healthcare professionals dealing with SCI clients. So, Peter is 28 years old. 19 years ago, he was involved in a traumatic motor vehicle accident. With reference to figure 1, Peter's T4 vertebra was completely transected, and so now he has thoracic paraplegia. Although confined to a wheelchair for mobility, he is functionally independent with daily living activities, bowel and bladder management, and drives with hand controls. Whilst Peter is generally sedentary, his body weight has remained stable at 75 kilos for the past 3 years, but his body mass index, or BMI, is 32 kgs per meter squared. His physical exam findings will be discussed later in further detail. Following an SCI, Peter's reflexes may be affected. They may be hyperactive or hyperreflexic. Hyperreflexia is suggestive of an upper motor neuron disorder, whereby lesions that damage the descending tracts decrease tonic inhibition of the spinal segment. In doing so, these lesions facilitate reflexes that are mediated at only the level of the spinal cord. As such, the myotactic or stretch reflex is hypoactive at the level of the lesion and hyperreflexic below the level of the lesion. This explains why Peter had very brisk 3+ reflexes at both the knees and ankles following a tendon tap. The exact mechanism responsible for hyperreflexia is unknown. However, several observed physiological changes have been postulated to contribute to hyperreflexia. This includes alpha motor neurons hyperexcitability, changes in intrinsic properties of alpha motor neurons, and decreased presynaptic inhibition of type 1A terminals. However, the delay in onset of hyperreflexia suggests that there may be another mechanism involved. As such, a change in the electrical coupling mediated by neurons by the gap junction protein connexin 36 may contribute to a result in hyperreflexia. However, being a recently introduced mechanism, the role of gap junctions and electrical coupling in SCI needs to be explored further, particularly during the transition to hyperreflexia. Following a T4 SCI, bladder function is also affected. This occurs due to disruption of neural pathways between the pontine, micturition, and storage centers and the higher brain centers. Looking at that lower half of figure 3 in the spinal cord section, parasympathetic activity mediated by the pelvic nerve, sympathetic activity mediated by the hypogastric nerve, somatic efferent activity mediated by the pudendal nerve, and the subsequent coordination of the relaxation of the external sphincter muscle and contraction of the detrusor muscle are all affected, be it in terms of promoting micturition or inhibiting it. This results in a spastic bladder, whereby individuals such as Peter lack awareness of bladder filling, storage, and voluntary control of micturition. This mild overdistension of the bladder also triggers vasoconstriction caudal to the level of injury, and thus there is an acute rise in blood pressure. As baroreceptor function and parasympathetic control of heart rate travel via the cranial nerves, these responses remain intact. Thus, there is also an accompanying baroreflex-mediated vasodilation above the level of injury. This accounts for Peter's responses of intermittent pounding headaches and sweating. It also explains why he's currently taking Detrol, an anti-muscarinic medication for spastic bladder. Credamain and Jonas in 2002 showed that administration of Detrol over 12 months results in a 21% decrease in micturations per 24 hours, a 25% increase in volume voided, and patient perception of bladder condition improved in 75% of subjects relative to their baseline measurements. However, the fact that the participants did not actually have SCI and the lack of follow-up after that 1 year affects the ability to generalize these findings to the SCI population, and as such, these are potential limitations of this study. There are 5 main cardiorespiratory changes associated with SCI. Resting blood pressure in individuals with high thoracic SCI is approximately 15 to 20 millimeters of mercury lower than in the able-bodied population. Recent literature suggests that this is due to disruption of efferent pathways from the vasomotor center to the spinal sympathetic neurons, originating in the intermedial lateral nuclei of T1 through L2 segments. These are involved in vasoconstriction, as well as impairment of baroreceptor reflex control. This results in excessive pooling of blood in the organs and viscera. Thus, Peter's low resting blood pressure of 105 over 63 millimeters of mercury is observed. Although there is a loss of supraspinal control of sympathetic nervous system, the vagus nerve is unaffected by SCI. As such, the vasovagal reflex can be elicited by visceral afferent input, like a rapid change in position, to the vagal centers in the brainstem. Normally, this reflex is opposed by sympathetic activity. Thus, post-SCI, this reflex is left unopposed and can lead to reflex bradycardia. According to Worth et al. In 2007, approximately 13 to 35% of thoracic SCI patients have bradycardia. In severe circumstances, this unopposed reflex can also result in asystole or absence of electrical activity in the heart. High thoracic SCI also affects respiratory muscle function. However, the severity of ventilatory failure and requirement of assisted ventilation really depends on the level of SCI. In Peter's case, the loss of abdominal muscle contraction, as this is innervated by segments T6 through T12, will result in paradoxical breathing. That is, his breathing will predominantly be achieved by the diaphragm alone, as this main muscle of ventilation is innervated by segments C3 through C7 and is still intact post-SCI. Moreover, as the intercostal muscles involved in coughing and deep breathing are innervated by spinal segments T1 through T7, Peter's ability to cough and breathe deeply may be compromised. This has important implications as failure to cough and remove foreign material, such as dust, mucus, or saliva from the lungs, can lead to a higher incidence of respiratory complications. This includes aspiration difficulty, pneumonia, and atelectasis, or a state of atrophy and airlessness in part or whole of the lung. In accordance with Hung 2011, edema is another common cardiovascular change present in individuals with SCI. The development of edema is related to decreased peripheral vascular resistance, decreased muscle tone and paralyzed limbs, and increased venous pressure and abnormal pooling of blood in the abdomen, upper and lower extremities caused by immobility. Catecholamine levels are also affected by SCI. With reference to Table 1, Monroe and Robinson in 1960 showed that individuals with SCI above T6 had significantly lower epinephrine and norepinephrine levels compared to the able-bodied population. Although the study may be 50 years out of date, recent studies conducted by Clayton, Steves, and Krosikoff in 2006 and Frey in 1993 support these findings. Following Peter's SCI, there are two main cardiovascular complications that he may experience in the future. This includes cardiovascular disease, or CVD, and dyslipidemia. As SCI individuals generally live sedentary lives, they are at higher risk of CVD than the able-bodied population. Asymptomatic CVD occurs at earlier ages after SCI, and its symptoms may be masked by interruption of ascending afferent pain fibers, conveying warning of impending myocardial damage or death. Dyslipidemia and an atherogenic blood lipid profile are also commonly reported. That is, they have elevated total cholesterol, low-density lipoprotein levels, and depressed high-density lipoprotein levels. Although their elevated TC and LDL levels are similar to those observed in the able-bodied population, are only 8 to 9% different, their low HDL levels are significantly different, by up to 30%. HDL levels are inversely related to CVD risk, and as such, over 60% of individuals with SCI have HDL levels above the criterion score for high CVD risk, which is an HDL level above 0.91 millimoles per liter. That being said, one potential criticism of the Bowman et al. 1999 study is that only Caucasian, Latino, and African American ethnicities were examined, and therefore caution is warranted when generalizing these findings to the Asian population. In the future, Peter may also experience spasticity, a musculoskeletal complication of SCI. Spasticity contributes to muscle contractions or permanent shortening of muscles, tendons, or ligaments. This is the predominant negative effect of spasticity, but others include pain, decreased mobility, and range of motion, all of which interfere with sleep quality and daily living. As Peter has mentioned, he has poor sleep quality, his range of motion at the shoulder is already mildly reduced, and he experiences mild pain on the right with arm elevation in the sagittal plane. He is already experiencing mild spasticity. Furthermore, despite the fact that he is currently taking Larazzol, a muscle relaxant medication, there is a relative lack of evidence-based support for Larazzol's therapeutic efficacy, and furthermore, this musculoskeletal complication cannot be cured. Fortunately for Peter, CVD, dyslipidemia, further spasticity, and muscle contracture are all complications that can be prevented through exercise interventions. Peter's BMI of 32 kg per meter squared, suggesting that he's class 1 obese, also gives further evidence for an exercise intervention. Although BMI does not take into account age, gender, ethnicity, and does not distinguish between lean body mass and fat mass, it is significantly correlated with total body fat, with a Pearson correlation coefficient of 0.75 to 0.82. His BMI is clinically significant, as obesity can increase the likelihood of Peter developing CVD by 1.28 times. It can also increase his risk for type 2 diabetes and certain cancers such as esophageal cancer and colorectal cancer. In terms of the actual intervention, it is recommended that Peter's waist circumference first be measured. Waist circumference has been shown to modestly increase the prediction of CVD risk in younger subjects less than 65 years old once BMI is known. If his waist circumference is over 102 centimeters, an exercise intervention should then be implemented. such, PETA should engage in aerobic exercise 3 to 5 times weekly at a low to moderate intensity, start with 10-minute bouts initially and then gradually work up to 20-minute bouts, and be encouraged to engage in sitting volleyball, as he was active in this sport prior to his SCI. Resistance training is also important. The repeated pushing motion of wheelchair movement can result in the shoulder and chest muscles becoming overused and prone to injury, whilst the back muscles, which are not involved in this pushing motion, can become weaker. Thus, it is imperative that PETA engage in circuit resistance training, or a series of 6 alternating isoinertial resistance exercises on a multi-station gym with high-speed, low-resistance ergometry. Ideally, 2 non-consecutive sessions weekly, 3 sets of 8 to 12 reps per exercise at moderate intensity. Flexibility training is also necessary to avoid further spasticity and muscle contraction. As such, upper body range of motion exercise should be conducted daily, stretching only to the point of mild tightness, holding that stretch for 20 seconds, and trying to do 2 to 4 reps per exercise. A recent study conducted by Nash et al. In 2007 showed that 12 weeks of circuit resistance training can increase VO2 max by 30% and increase isoinertial strength by 12 to 30%. That being said, the study had a small sample size of 7 participants, and therefore makes it difficult to make generalizations to the wider population. Furthermore, the lack of a control group and the exercise history of each participant not being taken into consideration may affect the accuracy of results obtained. During exercise, PETA should be closely monitored due to increased risk of acute autonomic dysreflexic episodes, fractures and joint dislocation of lower extremities, post-exercise hypotension, and thermal dysregulation. As such, a supervised program would be recommended. During PETA's last physical exam, he addressed concerns about autonomic dysreflexia, and he is justified in his concern. Autonomic dysreflexia, or AD, is particularly common in individuals with complete SCI above T6, with the lifetime frequency among SCI individuals being anywhere between 19 to 70%. AD is characterized by sudden uncontrolled response in the sympathetic nervous system. A rise in systolic blood pressure of 20 to 40 millimeters of mercury above the normal level can in itself be a sign of AD. AD can also present with a variety of symptoms, from severe headache, profuse paradoxical sweating, flushing and piloerection above the level of injury, to blurred vision and dyspnea. If left untreated, it can also lead to intracranial hemorrhage, retinal detachment, seizures, and death. Acute management of AD initially involves non-pharmacological measures. In accordance with Clayton and Korsakoff in 2006, an AD individual should be placed in an upright position to induce pooling of blood in the abdominal and lower extremity vessels, thereby causing a reduction in arterial blood pressure. Furthermore, tight clothing should be loosened or removed to enable further blood pooling below the level of injury. Possible triggers for peripheral sensory afferent stimulation, like visual or auditory stimuli from the external environment, should also be removed. The cause of the AD episode should then be determined. In 85% of cases, it is due to a full urinary bladder as a result of retention or bowel impaction. However, if systolic BP continues to be at or above 150 millimeters of mercury, pharmacological treatment needs to be employed. As such, antihypertensive medications with a rapid onset and short duration of action should be used, and captopril is one example. Captopril is a specific competitive inhibitor of angiotensin I converting enzyme and has been shown to be safe and effective for AD management in 80% of episodes. However, the Spinal et al. 2000 study has its limitations, such as the small sample size of 26 SCI participants and lack of follow-up data on whether a second dose of captopril would effectively lower systolic blood pressure. In conclusion, this presentation should direct your attention and deepen your understanding of the physiological mechanisms responsible for hyperreflexia and an overfull bladder. As healthcare professionals and academics, we should also be aware of the various cardiorespiratory changes that occur due to SCI, as well as the signs, symptoms, and management of autonomic dysreflexic episodes. This information should also encourage the use of exercise to effectively manage responses following a spinal cord injury and prevent complications from arising in the future. Thank you for listening.